Time. It's my pleasure to introduce Dr. Michael Lee as our first Grand Round speaker today. Dr. Michael Lee is a transplant hepatologist based out of both the San Francisco General Hospital and at UCSF. He earned his medical degree at Mount Sinai in New York, where he also completed his residency. And then he completed his GI fellowship at the Brigham and Women's Hospital before coming to UCSF for transplant hepatology fellowship. And since he joined our faculty in 2022, he works both in the general GI side on the inpatient service at the general and as a transplant hepatology hepatologist at UCSF. His research work focuses on the relationship between the immune system and liver disease. And despite all of his accolades, we all know Dr. Lee for his really friendly nature on service, and as well as readiness to mentor any and all of us fellows. Outside of the hospital, he spends a lot of his time convincing his almost 2-year-old daughter, Lydia, to root for his hometown Boston sports teams, which is definitely a challenging task growing up in the Bay Area. But today we are very fortunate to have Dr. Lee share his insights on portal hypertensive bleeding.
Thanks so much, Lakshmi. And I guess it's a good time for Lydia to be getting older because the Celtics just won. So she there hasn't been any screen time, so she hasn't actually witnessed any Boston sports teams yet. But we'll get there eventually. Well, it's nice to see everybody and nice to meet some of the first year GI fellows. I met a couple of you. I know two of you who were my interns when I was an LTU fellow. So that makes me start to feel a little bit old. Um, this topic is, despite not really being related to my research, is very near and dear to my heart because this is really rooted in the physiology of portal hypertension. And I find that really fascinating. And it's one of the main reasons why I became a transplant hepatologist. And I think this is also a really timely topic, not just because the first years are starting on service, but also the AASLD guidelines for portal hypertensive bleeding came out technically this year. They were released at the end of last year, so we kind of knew about them, but they were formally published earlier in 2024. So sort of hot off the presses, and this is actually an updated presentation from last year's because of the updated AASLD guidelines. Cool. So here are the objectives of my talk today. We're going to recognize how management of portal hypertensive bleeding is derived from the pathophysiology of portal hypertension. We'll apply non-invasive assessments to diagnose clinically significant portal hypertension and identify indications for screening and prophylaxis. This part's going to be the big updated portion where we talk a lot more about non-selective beta blockers because that's the sort of new hot topic. Management of acute portal hypertensive bleeding, and then we'll talk a little bit about disparities in management of patients with portal hypertension. And just as a reminder why this is important, obviously, if you have portal hypertensive bleeding, by definition, you have decompensated cirrhosis. But if you have compensated cirrhosis, your median survival is 12, maybe even more years without a transplant. Once that switch flips and you have decompensated cirrhosis, including a variceal bleed, your median survival goes down to 1.8 years. Gastroesophageal varices are present in 50% of patients with cirrhosis, and specifically after variceal bleed, 6-week mortality is 15 to 25%, which is very, very high. So here's an outline that will be sort of following throughout the talk. I'll be doing a take-home point slide after most of these, the sort of longer sections, which reiterate the most important clinical pearls. So if you zone out, I'll call your attention to those take-home point slides, and so all you need to do is pay attention to those slides. So we'll start with physiology, which again is something that I really love. And as I mentioned, the older hepatology AASLD practice guidance was from 2017. The new AASLD guidelines were just published officially in May of 2024, so very new. So this is now an updated talk based on that practice guidance, as well as the slightly older Baveno 7 guidelines. By older, they were published in 2021, 2022. So this is still a figure from the old guidelines. They removed this figure for the new guidelines, but I really like it because this figure shows the pathogenesis of portal hypertension and the various sites of action of currently recommended therapies to reduce portal pressures or to treat varices. And we'll be referring back to this figure in just a few slides when we discuss treatments to reinforce the rationale behind most of our therapies. In terms of what causes portal hypertension, most of the resistance in the portal circulation is due to mechanical issues related to cirrhosis, like fibrosis, as you might expect, direct vascular distortion from cirrhotic nodules and microthrombi. There's also some contribution of direct intrahepatic vasoconstriction due to endothelial dysfunction. And so how do varices, which are portosystemic collaterals, affect portal hypertension? Because after all, varices form as a compensatory mechanism by the body to try to offload a high pressure system. So you might expect that varices are helpful. And so we'll be doing a little bit of physics or math, I guess. So this is Ohm of Ohm's law. So here's a circuit. And the reason I bring this up is because we're going to be using Ohm's law to talk about portal hypertension. So Ohm's law in physics, you might recall, is V equals IR, or voltage equals current times resistance. You can convert that to fluid dynamics. And so delta V becomes delta P, or delta pressure. So the change in pressure over a system equals flow, which is current, so whatever's going through the system, and then resistance stays resistance. You might remember from maybe your ICU days when you talk about mean arterial pressure, what the mean arterial pressure equation is MAP minus CVP equals cardiac output, which again is the stuff that's flowing around your body, and then times your systemic vascular resistance, which is your resistance. Oftentimes the CVP is pretty negligible compared to the MAP, and so you can simplify this equation to MAP equals cardiac output times SVR. And then specifically for the portal system, the delta pressure there is your portal vein pressure minus your hepatic vein pressure. So that's by definition your portal pressures. The flow is the portal blood flow going into that system. The resistance is the portal system resistance, which, as I mentioned, is mostly mechanical with some component of vasoconstriction. So here's your HVPG equation simplified. So going back to the question about how varices, which are portosystemic collaterals, affect portal pressure, this is not a trick question, but if a patient develops varices, which of these variables on the right question, on the right side of the equation is affected? And so if you have varices, which are supposed to sort of be a compensatory response to higher pressures, what you're doing is you're diverting flow away, so your portal flow is decreasing, and so theoretically, all else being equal, your portal pressure should also be decreasing. The problem with that is that cirrhotic patients have this increased gut translocation of bacteria to the mesenteric lymph nodes for multiple reasons. Changes in the gut microbiome, tight junction dysfunction, pro-inflammatory cytokines, which cause release of nitric oxide. Nitric oxide is a really sort of key driver in a lot of bad things that happen in cirrhosis. It's a potent vasodilator. It causes significant splanchnic vasodilation. And that splanchnic vasodilation, as you might expect, causes increased blood flow into the portal system, which counteracts the decrease in the blood flow resulting from portosystemic collaterals. And so you kind of get this net no effect on portal resistance. So even though varices you think might be helpful for offloading portal pressures, they don't actually do that much. This is a very quick aside, not directly related to portal hypertension or bleeding, but this is a quick aside about one of the mechanisms of the ascites formation, which is related to portal hypertension, which applies a very similar concept and also contributes to a hyperdynamic circulatory state that further increases portal flow and then portal pressure, and then that's how we get back to risk of bleeding. So here's the mean arterial pressure equation again. I've written out cardiac output as heart rate and stroke volume. Here's SVR. So as I mentioned, splanchnic vasodilation leads to decreased mean arterial pressure because you're reducing the resistance, so you're reducing your mean arterial pressure. And then that causes this whole cascade here. You get baroreceptor activation, you get activation of the renal sympathetic nervous system, you get activation of RAS. And so the end result is sodium and water retention, which leads to ascites formation. And so this is sort of how ascites forms. At the same time, because your mean arterial pressure goes down, your body's trying to compensate for that. And one of the ways it can do that is by increasing your cardiac output. And again, even if you can never fully compensate for the reduction in SVR by increasing your cardiac output, that cardiac output, when you sort of zoom in on the portal system, actually does increase portal flow, and so therefore is also a mechanism by which portal pressures increase. We're going to be talking about mean arterial pressure more in the context of beta blockers, but mean arterial pressure is really important. This is a very old study now, but they just looked at whether patients hospitalized with ascites who had a MAP of greater than 82 versus less than 82, and you can see that the survival curves are very, very different here, and that it's much better to have a higher mean arterial pressure. They did the same thing for markers of low mean arterial pressure. So plasma norepinephrine, which is just levo-fed, your body makes its own pressors, and so when your mean arterial pressure is low, you're going to release more norepi, and so again, having a high plasma norepi is a bad sign. Same thing with urinary sodium, same thing with GFR. All right, back to actual portal pressures and specifically the therapies for portal hypertensive bleeding, either for prophylaxis or treatment that you've all heard about or used at one point or another. So we'll start with beta blockers, and this is a really hot topic, which we'll expand upon a little bit later in this talk. So why do we specifically say non-selective beta blockers? Why not metoprolol? Well, so that goes back to Ohm's law. So here's the equation again. Beta 1 blockade decreases cardiac output, which decreases portal flow. So that's great, because that'll reduce your HVPG. Beta 2 blockade causes splanchnic vasoconstriction, which also decreases portal flow. And then, so you're mostly affecting this part of the equation with a non-selective beta blocker. But you're affecting it in two different ways. Carvedilol, which is, as you guys will learn, we are a pretty big fan of, is a special non-selective beta blocker that also has alpha-1 antagonism. And alpha-1 antagonism causes intrahepatic vasodilation. So levo's action, which is a pressor, is mostly via alpha-1 agonism. So we're doing the opposite here. So you're going to get vasodilation. Once you get alpha-1 blockade, you get intrahepatic vasodilation, and then you're decreasing the portal resistance. So you're actually affecting both components of the right side of the equation now with the carvedilol. So unsurprisingly, there's pretty good evidence that carvedilol is more effective at reducing your portal pressures than nadolol or propranolol, which are the pure non-selective beta blockers. Because the alpha-1 blockade also causes systemic vasodilation, it also wouldn't be surprising to know that it decreases your mean arterial pressure more than nadolol or propranolol, which sometimes can limit using carvedilol or Coreg over the other beta blockers. So again, here's how the non-selective beta blockers work, increasing cardiac output. So we're blocking that. We're blocking that process, causing splanchnic vasoconstriction, and then here's carvedilol, which also separately affects the portal resistance. All right, so here are the somatostatin analogs of vasopressin, somatostatin itself, and an octreotide. So they're right here. So they cause splanchnic vasoconstriction. So it blocks this vasodilation component. If you vasoconstrict, you decrease portal flow. If you decrease portal flow, you're decreasing portal pressures. So that's how these things work. And here's some of the here's the endoscopic things that we can do for varices. So here's endoscopic treatments, sort of directed treatments against varices. So endoscopic variceal ligation is a local therapy. We basically are putting rubber bands on varices until they're obliterated. There's cyanoacrylate injections, EUS guided coil injections, BRTOs, which are local therapies to block or obliterate gastric varices. But just a note, none of these therapies affect portal pressures. They're all local treatments. So they're all right here. You're just doing something to varices themselves. And so you're not actually reducing portal pressures. You're sort of temporizing things. Yes, you can get things scarred down, but that doesn't mean that that the varices can't come back. And so we're not sort of addressing the underlying problem. I haven't mentioned a TIPS. We'll talk about that later because a TIPS is obviously very different. All right, so here's the first take-home point slide. So if you weren't paying attention and just want to tune in now, here are the key points. Portal hypertension is a resistance and a flow problem. Non-selective beta blockers act in two distinct ways to reduce flow. And then Coreg has an additional benefit of reducing resistance. So it's better at improving portal pressures at the cost of also reducing some systemic vascular resistance. And then endoscopic therapies, which we'll talk about later, don't address the underlying portal hypertension. So the underlying problem is still there. All right, so then let's move on to the second part of the talk, which is screening and primary prophylaxis of varices and bleeding, and really when to start and also when to stop beta blockers, which is a very hot topic now. So this is the invasive way to measure portal pressures, and traditionally in 20, 30 years ago, the only way that we could assess portal pressures. So this is a transjugular portal pressure measurement. So you access the IJ, you go down into the hepatic vein, you have a catheter floating in the hepatic vein, you get a wedged pressure where you blow up the balloon. You get a free pressure where you take down the balloon, and then you subtract those two to get your HVPG. The free hepatic vein pressure is subtracted to correct for intra-abdominal pressure, or in some cases, for example, if you have somebody with right-sided cardiac dysfunction, post-sinusoidal pressure to actually get the true portal pressure. This is not perfectly accurate. You can have pre-sinusoidal causes of portal hypertension that where you can have a normal HVPG, but in most cases, and certainly in patients with cirrhosis, this is the traditional invasive, most accurate way to measure pressures. So this is a figure from the Venous 7 guidelines. We'll break this down a little bit further, but indications of variceal screening are currently based on the presence or absence of clinically significant portal hypertension, which is defined as an HVPG of at least 10 or higher. We'll go over the individual components of this in more detail, but essentially patients without an HVPG of greater than or equal to 10 don't need variceal screening, which means that we need to discuss how to non-invasively identify clinically significant portal hypertension, because we're not just going to be doing transjugular portal pressure measurements on everybody. So FibroScan, most of you have probably heard of, or transient elastography, is a non-invasive ultrasound-based probe, transmits vibrations to the liver, and then the velocity correlates with the degree of scarring. It's validated for staging most forms of chronic liver disease. It's non-invasive. It's very quick to do. It takes 5 minutes to do. Here's some general cutoffs. They've sort of varied based on the specific liver disease, but generally, there are sort of reasonable cutoffs where you can sort of, anything less than 6 is pretty good. Anything in the teens is starting to get really bad. I won't go over the older versions of this talk. I actually went over some of the older studies looking at validating FibroScan for as a way to measure clinically significant portal hypertension non-invasively. We're not going to do that because I'm just going to jump straight to the new ASLD guidelines. And so this is a figure from those guidelines. It's a little bit busy. The next slide really simplifies things, but I'm just going to take some time to walk through this because I think it's interesting and very important. So the first row here is liver stiffness measurements and liver stiffness measurement ranges. Green is obviously good, and then red is bad. This is specifically using FibroScan. We'll talk about alternatives to FibroScan in just a little bit, but FibroScan is the most studied technology with the best cutoffs. So here's FibroScan, liver stiffness less than 10. You can safely rule out cirrhosis, and even though you can't rule out a component of liver fibrosis, you can be very confident that they don't have cirrhosis. You go one column over, liver stiffness between 10 and 15, and compensated cirrhosis is possible, though clinically significant portal hypertension is unlikely and can be ruled out completely if your platelet count is also above 150. We move one column over to the right, and now you're in the 15 to 20 range for your liver stiffness. These are patients with definite cirrhosis. They're also likely to have clinically significant portal hypertension. But if your liver stiffness is less than 20, your platelet count is greater than 150, which are really the cutoffs that you need to remember. That rules out varices needing treatment, and these are the patients who can avoid screening endoscopies. Conversely, if you have a platelet count of less than 110, that increases your probability of having clinically significant portal hypertension. And then you move over to the right, your liver stiffness is above your liver stiffness over 20, and that essentially rules in clinically significant portal hypertension. Certainly, once you get to greater than 25, you can be very confident in that. So here's some alternatives to FibroScan. So they listed some cutoffs for MRI elastography. ELF, which is actually a not imaging based, it's actually a blood marker based, and then some ultrasound based elastography measures. Here's some proposed cutoffs, but they're less well validated. They're especially the ultrasounds are subject to cross manufacturer variability, which is actually why ultrasound elastography reports will mention the brand of the machine used, because the cutoffs differ depending on the brand. So ideally, liver stiffness measurements as measured by FibroScan are best. But if you're really in the green range for these other types of non-invasive measurements, that's probably reasonable enough. All right, so that was a lot of boxes. I sort of hacked out all the stuff that you don't need to remember. This is a slide that has the numbers that you should remember. So again, if a patient has a liver stiffness on FibroScan of less than 20 and a platelet count of greater than 150, that rules out varices needing treatment. You can safely avoid EGDs. With that being said, and this is something that we think about in the outpatient setting, they'll still need annual FibroScans for liver stiffness measurements if you're trying to avoid endoscopies this way, because liver stiffness can be dynamic, and if their liver stiffness goes up, then they will no longer meet this criteria. I'm personally a little bit more hesitant to use non-FibroScan methods given the limitations of the current data. It's probably clinically reasonable to avoid doing screening EGDs in patients who have normal platelets and their numbers are at the lower range of the yellow box. But once you're starting to get towards the borderline, I don't know how confident I feel about the upper ranges of the cutoffs. All right, so we talked about non-invasive clinically significant portal hypertension assessment. So let's talk about non-selective beta blockers, which, as I mentioned, is a very hot topic right now. So the PREDESI trial was published in the Lancet in 2019. It's the strongest evidence thus far of clinical benefit associated with non-selective beta blocker therapy. So it's a trial of 201 patients with compensated cirrhosis. They all had transjugular portal pressure measurements. So they all had invasively proven clinically significant portal hypertension without high risk varices. They also all got IV propranolol while they were getting their transjugular portal pressure measurements, which is not something that is currently standard of care. And all patients responded to IV propranolol. So they're really selecting the patients who are sort of the best beta blocker candidates, I suppose. They all have proven portal hypertension. They all responded to an IV beta blocker before being enrolled in the trial. And so these are the patients who are going to do the best on beta blockers. Half received placebo, half received beta blockers. Of those, 2/3 got propranolol, 1/3 got Coreg, and then their primary outcome was hepatic decompensation. And so beta blockers are great. Beta blocker treatment reduced risk of hepatic decompensation. Their hazard ratio was 0.5, and it was not associated with increased risk of adverse events. There's a few caveats. The mean propranolol dose was 95 milligrams per day, which is high. The mean Coreg dose was 19 milligrams per day, which is relatively high and actually above what we consider a therapeutic dose nowadays. It's not uncommon that patients won't tolerate those doses. In addition, I mentioned the IV propranolol thing during the portal pressure measurements. That's not something we do. And then most patients had untreated Hep C in the study because that's sort of the patient population that was being enrolled when they were back in the day before the DAAs, and now we have DAAs. And so this is not necessarily the population that's representative of our current liver disease population. But with that being said, a very strongly positive study in terms of reaching their endpoint. Just as a reminder, Coreg is more effective than pure non-selective beta blockers. This is the same slide that I showed earlier. All right, so there's a major movement towards more aggressive beta blocker therapy. So who should we be treating? So let's start with patients with compensated cirrhosis who don't have clinically significant portal hypertension. So here's their HVPG between 5 to 10. For these patients, non-selective beta blockers are not recommended. There's no evidence that in patients with compensated cirrhosis and not clinically significant portal hypertension, that treatment reduces risk of decompensation. With that being said, if I have patients in this group and they have AFib or they have heart failure and they're on metoprolol, I'll often just reach out to their cardiologist and ask if we can transition them to CoReg just to kill two birds with one stone. All right, we move one column over, and this is compensated cirrhosis, but now with clinically significant portal hypertension. And these are the optimal patients to treat um, with a non-selective beta blocker, which then, as a reminder, they no longer need screening EGDs because either beta blocker therapy or variceal ligation are reasonable options for primary prophylaxis for variceal bleeding. Some patients will have general contraindications or intolerance to non-selective beta blockers. And if you do, then you'll need variceal screening in general every other year as long as they remain compensated. And then because if they are not able to take or tolerate non-selective beta blockers, if you find high-risk varices, those are the patients who should be banded. And then the ASLD guidelines recommend a pretty stringent interval of every 2 to 4 weeks in terms of repeating the endoscopies until obliteration. Uh, that's pretty strict. I mean, if we can try to get to 4 to 6 weeks, I think that's great. I don't know that we've ever been able to repeat every other week. And then once you get a successful obliteration, you repeat a EGD at 6 months. If there's no banding needed, then you move to annual endoscopies. So what about patients with decompensated cirrhosis? Are they good non-selective beta blocker candidates? So there's some evidence that non-selective beta blockers can be harmful, and that there's sort of a tipping point where um, if you're not sick, if you're not too sick, and you're sort of before that tipping point, beta blockers are helpful, and then if you get too sick, then beta blockers can potentially be harmful. So this is a retrospective study of 151 patients with refractory ascites. Half of them were on beta blockers, half were not. And the beta blocker group had actually worse survival after adjusting for liver function metrics and liver cancer. Half of the non-selective beta blocker patients were on huge doses of propranolol. So that's potentially an explanation because that's a very high dose. And one potential hypothesis of this effect is that using non-selective beta blockers in patients with refractory ascites might prevent the cardiac compensatory response that occurs after a large volume tap to maintain a stable mean arterial pressure after you get those really huge fluid shifts if you're taking out 10, 12 liters of ascites. But again, this was a very high dose of propranolol. This is a retrospective study of 607 patients with ascites. And what was interesting is that before patients developed SVP, non-selective beta blocker treatment was great and sort of mirrored the Prodesi trial findings. But then of the 182 patients who developed SVP, non-selective beta blocker treatment increased the risk of death. So there's probably this window period during which non-selective beta blockers are good, and then even with ascites, and then when you further decompensate, that could be potentially put you at risk of lower blood pressures, leading to hepatorenal syndrome. And so that's potentially the explanation for that window period. There's some conflicting evidence. A couple other studies have been published in slightly varying populations that have challenged this concept of beta blockers potentially being harmful in sicker patients. This was a study looking at patients with ascites of all severities, not just refractory ascites. They saw a survival benefit with CoReg. This was a post hoc analysis of 3 RCTs, which contained patients with ascites and specifically looked at whether beta blocker therapy was associated with survival differences in those with refractory ascites here or diuretic responsive ascites. And they didn't find any change in survival in patients with refractory ascites, which might sound reassuring, but they also didn't see any survival benefit in the diuretic responsive ascites group, unlike other studies. So I'm not sure that this is perfectly generalizable. So let's circle back and talk about what the ASLD recommends in terms of beta blocker strategies in patients with decompensated cirrhosis. And then I'll provide a few caveats with my opinions, but I'll lay out the guidelines first. So patients with decompensated cirrhosis who aren't on beta blockers already obviously should get screening EGDs, and they should be getting those on an annual basis. If you find high-risk varices on screening EGDs in these patients, you can choose to start a beta blocker, or you can do band ligation. And ASLD has a preference to beta blockers because of the potential benefits beyond just preventing variceal bleeding. But ASLD also recognizes that there's potentially some risk here, and so they recommend that a beta block should be dose reduced or discontinued in patients who develop persistently low blood pressure, so systolics less than 90, or severe adverse effects. My personal opinion is that you should also be a little bit nervous or a little bit more cautious in patients with refractory ascites, and then certainly if somebody develops SBP, because these are both risk factors for developing hepatorenal syndrome, largely related to the fact that these patients tend to have lower mean arterial pressures. So I kind of view those conditions as surrogate markers for those with low blood pressures. But at the very least, ASLD is cognizant of the potential risks in patients with lower mean arterial pressures. See a comment in the chat about patients who have radiographic evidence of varices but not been scoped. That happens all the time. So just because you have radiographic varices doesn't mean that you'll have endoscopic varices. And so that's very, very, very common. Radiographic varices are not necessarily an indication to start non-selective beta blockers. And you also can't just say that because you see radiographic varices that they would have varices needing treatment on endoscopy. But with that being said, if you have radiographic evidence of varices, you have radiographic evidence of portal hypertension. Those are probably patients who might fall under the clinically significant portal hypertension group. And if they do, then you can give them a beta blocker, and then you don't need to worry about scoping them.
That's helpful. Thanks.
Yeah, of course. So I just wanted to finish a little bit of this prolonged beta blocker topic, which I chose to spend a little bit more time on because it's the hot topic now, with just a couple notes on dosing. So CoReg is great. It's our preferred beta blocker because it's more effective. And really, it's simpler to use too. It just has one therapeutic dose. If you get to 6.25 milligrams twice a day, we're good. Usually we start at once a day and then make sure they tolerate it and then go up to twice a day and then you're done. Some patients are on higher doses already because of heart failure, and that's up to the cardiologist. But of course, if somebody's on higher doses, that'll also work for our purposes. There's no heart rate goal for carvedilol, so it's not something you need to up titrate as long as you get to the 6.25 BID dose. And then ASLD again sort of cautions the blood pressure monitoring. Propranolol and lansoprazole do need to be up titrated based on heart rate. So you want to get it up to a maximum tolerated dose with a goal of heart rate of 55 to 60. I often see that patients who have variceal bleeding who are then referred to us, they get started on propranolol 10 BID and then get discharged after the variceal bleed, and nobody's up titrating it, and 10 BID is probably is clearly a subtherapeutic dose. So I tend to lean towards carvedilol, recognizing that again, carvedilol affects your systolic blood pressure a little bit more, so it's possible that patients might not tolerate it shortly after a bleed. All right, take-home points. Again, this is sort of all you need to know from that chunk. Again, the cutoffs for liver stiffness and platelet count are 20 and 150. If your liver stiffness is less than 20, your platelet count's greater than 150, you're good. Don't have to worry about anything. You don't need EGDs, but you do need annual fiber scans to make sure that your liver stiffness stays less than 20. Non-selective beta blockers are perfect in compensated patients with clinically significant portal hypertension. And then they are probably good in some decompensated patients, but I would be cautious if patients have low blood pressures, refractory ascites, or SBP. All right, so now we'll talk about actual management of acute portal hypertensive bleeding, which is, to be honest, mostly what you guys are going to be dealing with in the inpatient setting when you're on consults. All right, so risk factors for varices, unsurprisingly, severity of liver disease, So the more severe liver disease, the more likely you have varices or even high-risk varices, endoscopic appearance, your actual portal pressures, and then certainly if your HVPG is greater than 12, that cutoff is associated with bleeding risk. Here's what varices look like endoscopically. So this is a normal esophagus, totally smooth. Here you can start seeing some small columns of varices, but they flatten completely. Here's some juicier varices that we would consider grade 2 or medium varices. Theoretically, they project into up to a third of the luminal diameter. And then here's really big, juicy varices that project into over 50% of the luminal diameter. Here's some red whales. I won't belabor this point, but unsurprisingly, larger varices are more likely to bleed. So here's the standard GI fellow dot phrase for bleeding and especially potential variceal bleeding. So you get your IVs in, you get your IV PPI, they might need to be intubated for airway protection. ASLD recommends an EGD within 12 hours specifically for suspected variceal bleeding, which is different from other types of upper GI bleeding. ASLD also recommends avoiding FFP or platelet transfusions of specific targets. The platelet transfusion is soft evidence. The FFP is medium evidence, I would say. There haven't been any clinical trials looking at FFP versus or platelet transfusions of certain goals. My personal practice is I never think about the FFP. Sometimes I would think about some platelets if they had really substantial thrombocytopenia, but I would be gentle with that. And then here's the bolded things that we'll talk about in the next couple slides that are I would consider are strongly evidence-based. All right, so your PRBC transfusion goal. So this is a clinical trial that you guys have probably all heard of at this point. Now 11 years ago, an RCT of 921 patients with upper GI bleeding, which is published in the New Journal of Medicine. They randomized patients to restrictive goal of hemoglobin 7, liberal goal of a hemoglobin of 9. And the restrictive strategy was associated with improved survival, less rebleeding, no increase in portal pressures. When they looked at the subgroup analyses of the study, they saw that a lot of this improvement in survival with the restrictive strategy was actually driven by the patients with cirrhosis and liver disease. Not all the 921 patients in this study had the underlying liver disease. So the idea is that probably, as I mentioned, you get your portal pressures depend on flow and resistance. If you're slamming somebody with blood, you're increasing their cardiac output because you're increasing the preload. You're getting more blood to the portal system. You're getting more flow into there, and you're increasing your portal pressures, which actively acts against you when you're trying to stop variceal bleeding. All right, so vasoactive medications and variceal bleeds. These are all based on kind of old data these days, but this is a meta-analysis from 2012 looking at kind of old studies. The use of vasoactive agents was associated with a significantly reduced risk of death within 7 days. Here's the sort of overall effect. Vasoactive agents were also associated with lower transfusion requirements and shorter length of hospitalization. And so what we recommend is you use octreotide for 2 to 5 days. And then once you're off the octreotide, assuming that they're clinically stable, at that point is a good reminder to start the non-selective beta blocker. All right, and then antibiotics. So this is also on this is a meta-analysis on slightly old data, but you can see that antibiotic prophylaxis technically reduces all-cause mortality a little bit, but it's statistically significant and probably clinically significant too, largely driven by a reduction in mortality from infection. So great, antibiotics are good, octreotide is good, transfuse a hemoglobin goal of 7. If they've got really bad CAD, maybe you bump that up to 8. All right, this is what band ligation is. So it's you place these rubber bands on variceal columns. You're interrupting blood flow. You're causing necrosis of mucosa and submucosa and replacement of varices by scar tissue. It's effective. Initial bleeding is controlled with banding and octreotide in 90% of cases, and the rebleeding rate after banding is 20%. Just remember, even though you're achieving variceal obliteration, if you're successful, varices will eventually recur because you're not treating the underlying portal hypertension. meta-analyses of trials looking at ligation versus sclerotherapy, which is something that I've only seen done once and is very rarely used these days, show that ligation or banding are associated with significantly lower rebleeding rates, lower number of sessions to be successful at achieving variceal obliteration, and lower mortality, which is why we do banding these days. So our practice after a variceal bleed is to repeat an EGD in 4 weeks. ACLE says 2 to 8 weeks to allow for healing of band ulcers before we go in and potentially do more banding. HVPG responders, so patients who actually had improvement in their portal pressures, and patients who got combined variceal ligation and non-selective beta blocker therapy had the lowest rebleeding rates. So for secondary prophylaxis, everyone gets banding plus non-selective beta blocker. This is totally different from that beta blocker discussion that we just had for primary prophylaxis. As soon as you're bleeding and as soon as it's secondary prophylaxis for a history of bleeding, you need both. All right, so this is TIPS, which I mentioned we were going to talk about, or transjugular intrahepatic portosystemic shunt. So a TIPS essentially bypasses the portal system to decompress portal pressures. So you can see there's a shunt going from the portal vein to the hepatic vein. So you're bypassing all the stuff that's going on in the liver. It can be used as salvage therapy in refractory bleeding or in patients who rebleed. It can be used for ectopic variceal bleeding. So this is obviously much less common than esophageal or potentially gastric varices, but you can get small bowel varices, you can get rectal varices. Those are really difficult to treat. You can always band anything sort of in the acute setting, but the banding is not going to be effective long term. So there's some contraindications to TIPS. So one is because you're bypassing this high pressure system in the liver, and you're sort of dumping portal inflow straight into the hepatic vein, which then goes to the IVC, you're going to get a lot more cardiac venous return to the right side of the heart. So you need to make sure that that patients don't have right-sided cardiac dysfunction or pulmonary hypertension, because otherwise their RV can blow. Hepatic encephalopathy. So again, you're sort of bypassing any sort of filtering that the liver is doing, and so if you have a history of hepatic encephalopathy, that can get worse, or even in the absence of hepatic encephalopathy, this can trigger hepatic encephalopathy. So it's a potential contraindication depending on how severe the underlying encephalopathy is. And then finally, MELD score. So MELD was actually originally designed to predict post-TIPS mortality. And then we realized that all those things were great for predicting short-term mortality from liver cirrhosis anyway, and then they got adopted into use for organ transplantation allocation. So MELD score, generally, if you're above the teens, that's a relative contraindication because you're going to do worse with the TIPS. So so-called early TIPS is not a new concept. This is a landmark RCT published in the New England Journal of Medicine all the way back in 2010, which showed that early TIPS in high-risk patients reduced risk of bleeding and risk of death, despite being a relatively sick group of patients. Median MELD was 18. I see a question about MELD. Oh, and I missed some other questions in the chat. Molly, you have to remind me which study you were referring to. I apologize, I missed your message, but we can talk about that at the end. Obliteration, no varices are grade 1. Technically, so you're not going to be able to ban small varices, so that would be pretty successful. Generally, oftentimes you just get so much scar tissue built up that everything's pretty scarred down, and that's generally the goal. But yes, I would say if you get to grade 1, technically that's good enough because you can't ban those anymore. And then do you use native MELD instead of MELD sodium or 3.0? We use MELD 3.0 just because that's what we think about these days. I think that question was related to the risk of death post-TIPS. Technically, original MELD, way back in, I don't know, 2000 something, was what they had developed to predict post-TIPS mortality. Honestly, if you compare MELD versus MELD sodium versus MELD 3.0, they're very similar. We got very incremental benefits with predicting waitlist mortality with transitioning from melt to melt sodium to 3.0. So you could honestly use any one of those. I generally tend to only think about melt 3.0 these days. Um, okay, so back to early tips. Again, these were relatively sick patients. Child-Pugh B or C, mean MELD was 18. So sort of on the borderline of acceptability for liver function. Oops, sorry. And you can see that in terms of overall survival, which is the Kaplan-Meier curve on the right, and then uh, time to rebleeding or issues with uncontrolled bleeding, you can see that the early TIPS groups were superior to the standard banding plus vasoactive medications.
Mike, can you reshare your PowerPoint?
Oh, sorry. Am I not sharing right now?
Not
No,
currently.
you're sharing. It's a view.
We can see.
Oh, Lakshmi, can you see it?
No, but I will figure it out.
Oh, I mean, I'll just stop share and then reshare in one sec.
Looks good.
Cool. All right, so this is a 2020 meta-analysis of almost 2,000 patients. A lot of these patients came from Garcia-Pagan's study and then subsequent studies that they did. But this sort of consistently showed that in terms of treatment failure, 6-week mortality, 6-week rebleeding, you can see that all of these studies favored early TIPS. It did separately increase the risk of hepatic encephalopathy, which we know about and is a sort of accepted potential side effect. So there's 3 separate classifications or categories of TIPS. So there's a preemptive TIPS, which is really what the studies I was just showing you are about. These are recommended by the AASLD within 72 hours of initial EGD in high-risk patients. So high risk means either Child-Pugh B7 with active bleeding at the time of endoscopy. So if you go in and you see active bleeding and you band, they're probably high risk, assuming that they meet the relatively low criteria of hitting 7 Child-Pugh points, or any patients with Child-Pugh class C disease. So the Cs don't need to have active bleeding at the time of endoscopy and are considered high risk. And these patients do better with the preemptive TIPS. Obviously, in the absence of absolute contraindication, so you need to get an echo. You need to make sure that they don't have horrible encephalopathy. Salvage TIPS is what we refer to for use in uncontrolled variceal bleeding. So if you're not able to control bleeding at the time of endoscopy, which is a very scary thing, then this is sort of an emergency TIP situation. And then rescue TIPS is for use in patients who rebleed after you get initial control with your scoping and your vasoactive medications. All right. So for the first years, you see the following on your EGD. So what is this? And the hint is that you can see something here that tells you where your scope is. All right, so this is so you can see that you're retroflex here because here's the scope. I know it's a little blurry. So if you're retroflexed and this is an EGD and also it kind of looks like the stomach, this is the stomach. So this is a big plump gastric varix that's actively bleeding. And so let's talk about gastric varices next. So here's the classification of gastric varices. So mostly they're GOV1s, which are esophageal varices that extend down the lesser curvature. These you can just treat just like esophageal varices in terms of prophylaxis, in terms of management for active bleeding. So you can just ban these and not worry. GOV2s are gastroesophageal varices that extend along the greater curvature. IGV1s are isolated gastric varices, and IGV2s these are pretty uncommon in the antrum, but usually you see them in fundus. So these ones over here, so the GOV2s, IGV1s, can't be treated the same as you would for esophageal varices. You know, you can ban anything acutely, but it's not going to be effective long term. So ASLD recommends that the treatment of choice for these bleeding gastric varices is TIPS or glue injection, which we'll talk about in a little bit. Balloon-occluded retrograde transvenous obliteration, or BRTO. There's also there's BATOs these days, which are anterograde. But like regardless, these are IR procedures that can be performed for funding varices with specifically gastrorenal or gastrospinal renal shunts, because that's how you access, or that's how the interventional radiologists access the fundic gastric varices. So they go into the shunt. They blow up a balloon in the shunt, and then they inject a sclerosing agent directly into the varices. This is a really effective procedure. It does increase your portal flow, and so it does increase your portal pressures, and so therefore your esophageal varices or ascites can get worse after this procedure. But a very effective procedure for treating gastric varices if you have the appropriate shunts to access. This was a small RCT out of China of only 64 patients with GLB2s or IgV1s. They were randomized to either glue injection or BRTO, and BRTO was associated with lower rebleeding risk and fewer hospitalizations. This needs to be replicated in larger studies, but it's at least a signal towards BRTOs being very effective. And I think I think colloquially, I found that BRTOs tend to be very effective. People are looking at EOS-guided coil embolization, so injecting coils for embolization along an absorbable gelatin sponge, so a hemostatic agent that forms a plug for treatment of gastric variceal bleeding, but this is also still experimental right now. So here are the actually the recommendations from the guidelines. So if you have GLB1s, which I mentioned, you can treat the same way as you would for esophageal varices. Those are the ones that extend down from the esophagus along the lesser curvature of the stomach. You can treat them exactly how you would with banding. You can do glue injection if you want, but generally, unless you have an advanced endoscopist in the room, it's just easier to do the banding. And then secondary prophylaxis, exactly the same as for esophageal varices, beta blocker and band ligation. For the GLB2s or IgV1s, ASLD now thinks that glue injection tips or BRTO are all potential first-line options and doesn't give preference to any one of these specifically. And then for secondary prophylaxis, if you get a TIPS or BRTO, you're done. You don't need anything else. Otherwise, if you went the glue injection route, it would be a combination of non-selective beta blockers plus more cyanoacrylate. So let's say that the glue injection failed and the team's calling IR for an emergent TIPS. So what can we do as a temporizing emergent measure? And so we can do tamponade. So there's a couple different ways to do tamponade. So Minnesota tubes or Blakemore tubes are essentially the same thing, except one has an esophageal suction port and one doesn't. It doesn't matter functionally from a clinical perspective. And so what the process is there's a gastric balloon and an esophageal balloon. You insert the tube down. Generally, you only blow up the gastric balloon. The esophageal balloon is only needed in rarer situations because usually the gastric balloon is enough, especially for gastric varices. The esophageal balloon isn't going to do anything. But even for esophageal variceal bleeding that's uncontrolled, because the columns travel upwards, applying balloon tamponade just with the gastric balloon is generally sufficient. And then, as I mentioned, you're only going to be treating GOVs because the balloon is right here. So if you have any IGVs, you're kind of stuck. The advanced endoscopist for esophageal variceal bleeds can also potentially put in fully covered metal stents as a separate way to do tamponade. So if you have an advanced endoscopist in the room with you and your endoscopic treatments fail, that might be a temporizing measure instead of taking out the scope, finding the Minnesota tube and then figuring out how to place it. And then one last quick thing about PHG and GAVE. So PHG is portal hypertensive gastropathy. You get this classic snakeskin appearance of the stomach. It's very, very, very common. If you scope any patient with cirrhosis, you're pretty likely to see something like this. And in GAVE or gastric antrovascular ectasia, which is watermelon stomachs, you see these sort of classic lines going down, sort of in a watermelon pattern, I suppose. So the key thing is that portal hypertensive gastropathy, as mentioned by its name, is associated with portal hypertension and is caused by portal hypertension. So you can treat it by treating the portal hypertension with non-selective beta blockers. GAVE is not caused by portal hypertension because it's only associated with portal hypertension in 30% of cases. And so treating the portal hypertension isn't actually effective for GAVE. And so first-line treatment right now is thermocoagulation. Really, you're only worried about treating patients with chronic bleeding or blood loss issues, with chronic anemia, and things like that. So as I mentioned, here's what APC looks like if you're treating GAVE. RFA is probably more effective, and I think that there's probably going to be a move to sort of try to do RFAs more frequently. There's a meta-analysis that one of my co-fellows did back in GI fellowship where RFA required fewer treatment sessions despite them being refractory to prior, sorry, this should say APC, refractory to prior APC treatment. So these are patients who essentially the RFA is very effective even in patients who are refractory to APC. Are there any recommendations for primary prophylaxis for large GOV2s? Yes. So I can go back to, I apologize if I didn't. Oh, in terms of, sorry, you're asking primary prophylaxis, yes. So I didn't include that in the active bleeding section, but yes, so recommendations for primary prophylaxis for large GOV2s without bleeding, you can do either non-selective beta blockers, or you can ask advanced endoscopy to do serial cyanoacrylate injections. I would sort of tend to lean towards the beta blocker for all the reasons we've talked about, in that non-selective beta blockers are great, unless they're too sick for that. Okay. Talked about GAVE. All right, take-home point slide. So again, this should hopefully summarize all the important points. IV antibiotic prophylaxis reduce mortality a little. It's really important to remember to start the non-selective beta blocker for secondary prophylaxis after the octreotide is discontinued. They need another EGD for banding in 1 month after variceal bleed. Preemptive tips within 72 hours in high-risk patients. So I'll remind you again, that's Child-Pugh B7s with active bleeding, active variceal bleeding at the time of endoscopy, or NECs. These are patients who you should think about calling IR for preemptive tips. And then GOV1 gastric varices can be managed similar to EV, to esophageal varices, and then other types require more specialized interventions. All right, so let me see. All right, so we have a couple more minutes. I'll just briefly mention some disparities in management. I think we'll skip the board's questions at the end. So there are some very clearly well-defined disparities in management of portal hypertension. Black and Hispanic patients were less likely to receive a TIPS in the study, and Black patients were more likely to have a delayed EGD over greater than 24 hours after admission, and were more likely to experience an hospital death. And then there's also disparities in screening for esophageal varices. This was a slightly more recent study. Among 157 patients with cirrhosis, Black and Hispanic patients were significantly less likely to receive variceal screening compared to non-Hispanic white patients. And the odds ratios are pretty substantial and robust. So this is just sort of emphasizing that just as in any other field of medicine, there are issues with disparities in how we treat patients that we should be cognizant and aware of, and that need to be addressed. And then the very last short bonus point for consults. This is actually now formally in the AASLD guidelines. So if you get called by cardiology to ask for a screening EGD to look for varices before a TEE, we do not recommend that. one of the three studies that the guidelines cited was a study that I was part of in GI fellowship, which we did purely out of frustration for being called so often to do EGDs before TED. So now you have actual formal ASLD guidelines that you can point to when you get called for this council question. And I will, for the sake of time, I will skip the board's questions and stop there.
Thank you so much, Mike. That was super high yield for all of us. I think we have maybe a minute for answering some additional questions in the chat. I think there was one from Marina and Donna. If you want to take a stab, and then we can take